Hello? Oh, there we go. There we go. All right, so for those of you who were here this morning, you got to see my very passionate boss, Dr. Joel Besmer. Guy's got some passion, right? I'm very, very excited to be here. Thank you so much. Our story is one where we started out fairly small. Dr. Besmer explained that our mission and vision really is to save primary care. We have grown over a very short course of time to win the state of Nebraska contract. Very, very exciting. It was mentioned by Dr. Kroll that Joel has the governor's ear, which he does. However, it was a fair fight for us to actually get that contract. So we have, over the past year, been mired in implementation with a government agency and United Healthcare. And let me tell you, that has been pretty exciting. So the first contract we got from United Healthcare was only 53 pages long. So we're working through that, along with a tremendous number of other implementation issues. And I want to give a shout out to Hint because they have gone above and beyond to get the platform ready for the state of Nebraska, have met unreasonable deadlines, and have done it very, very quickly and have worked well with us. So we appreciate that a lot. So the reason that we got the state of Nebraska, we had to work very hard for that. The reason we got it is because we have data, okay? When I first went to work for Strada Healthcare, I said, I need two things. I need two promises. The first is if we get a physician in our panel that doesn't carry forward the Strada brand, I need the ability to have that physician removed from the panel. So for those of you out there that may or may not know, sometimes it's hard to get rid of a physician if they're not doing a great job for the brand. So that promise was made to me, and thus far we've only lost one, and fortunately it was that physician's decision to do that. Secondly, I said we have to have data. I have an insurance background, and I know that people will only pay for things that they know are valuable, especially when you're talking about something intangible like healthcare. I didn't want to measure it in a way that was obtrusive to the provider because that was my prior life. I worked for a private ACO with 32 independent physicians, and we spent most of our time trying to figure out how to code things and very little time on patient interaction. So we need data, but we need to do it in a way that's smart and doesn't include the physicians. So thanks to KPI Ninja, who has worked very, very closely with us to let us decide what those metrics are going to be, we had data. I've got my outcomes here. I had to write them down because I can never remember this stuff. So on a per member, per month basis, for our employer groups who we are able to collect data on, for medical cost, we were able to save over the past year $287 per member per month, okay? For drug, $141 per member per month. So that's a total of $428 per member per month. When you take that to an employer, that is very meaningful for them. And I can tell you that KPI has put a tremendous amount of diligence into making sure that data is correct. The other thing I can add is we've recently added risk. So we've looked at the risk of the population that is not direct primary care versus the risk of the population that is. And I bet all of you would think that the people that pick primary care, direct primary care are less sick than those that don't pick direct primary care. Is that what you think? It's not the case. It is absolutely not the case. So we can begin to tell the story that direct primary care actually has positive financial outcomes that aren't necessarily related to the sickness of the population. The other thing that I want to point out is that these outcomes were across all of our providers. Dr. Besmer already mentioned that most of our providers are affiliate providers, meaning they're hybrid. Again, one of my things that I wanted when I got there was we could get rid of a doctor if they didn't make sense. We're monitoring and managing these affiliates. They're very passionate about what they do, and they're returning fantastic outcomes for us. But none of that would be possible if we weren't paired with a consultant advisor from the very beginning that can see the trajectory of healthcare and understand that it can't go the way it's always gone, and trusted us enough to put direct primary care in with one of his employer groups. I'm going to turn it over to Justin.
Thank you, Lisa. Appreciate it. So greetings from the state of Nebraska, where it's so flat you can watch your dog run away for 3 days. So as Lisa will tell you, Mike's probably going to have to come up here and rush me off the stage because I get so excited when I talk about what's happening with direct primary care and really how we've been able to successfully integrate what you all are doing into the employer space. So what I'd really like to cover today is a question that I get asked a lot, and it's sort of an existential one, but how do you do it? How do you bring all this stuff together? And how do you make it work? So Lisa talked about some outcomes. Obviously, we tout those outcomes because we're living it every day. But a couple things I want to focus on just in terms of high level, and in about 7 minutes, I want to try to get as much of this out here as I can. But the reality is, the first way I answer that question is you really have to understand the dynamic of employer-sponsored health plan. That's just number one. You really have to understand the dynamics of how employers are motivated to select, implement, and deliver care to their employees, or deliver a program to their employees, right? So I remind people all the time that there's two types of buyers or decision makers inside of any corporate health plan solution. One is the HR function. How are HR people different from the C-suite or CFOs? They're warm, fuzzy people generally. How is this going to impact my people? Are they going to be happy? Are they going to get better outcomes, right? So that's number one, and they are your trust me population. Trust is a big issue with the HR function. The second function is your CFO, your C-suite function. Generally, they are not trust me people. Generally, they are prove it to me people. So I think that one of the biggest mistakes that I've seen some DPC practices make is they go into the employer and tell this awesome story about how they're going to deliver such great care and how they're going to make it such a meaningful experience to their employees. But they come unarmed with data. So the HR function's going, yes, I love this. This is something I want to deliver to my employees. But then they have a meeting with the CFO and he or she's going, so what? That's great that it's meaningful, but how is it going to impact my bottom line? And that's really, if you can really tailor your message and approach to both of those types of people, I'm telling you, you will be successful. Because we've already proven that it's possible. You heard Lisa mention that data and analytics is such an important and key part of the direct primary care movement, especially when we're integrating it in with employer-sponsored health plans. Without data, state of Nebraska wasn't possible. Just wasn't, right? Because you have a really high-functioning organization that needs numbers to make decisions. I mean, if you're telling your story, there's a lot of smart people in this room that provide wonderful, excellent care. But I can't stress to you enough just how important data and analytics is. If you haven't had the opportunity to go talk to Vineeth and his team, VJ and Isaac out there with KPI Ninja, I would suggest you do that. Those guys are wizards, and we've been together for 4 years now. And I would welcome you at all to join one of our discussions because we really get down into the real geeky data territory, and we have a lot of fun, lively discussions. So data and analytics is key, okay? So I want to pivot at this point also and go back to something that you heard Kat say, who was a couple of speakers ago, when she was getting into sort of the legal elements and the pitfalls potentially that you're going to run into when implementing direct primary care into an employer-sponsored health plan. There's lots of different considerations. But I want to point something out here that I think is really important. And this is going to sound strange coming from somebody in my position because I am one. But I would just point out that this is such a complex deliverable, but we're really trying to make it a simplified discussion when we go talk to employers. But behind the scenes, it's a very complicated structure. Lots of different moving parts. You have your TPA and your administration partner. You've got stop loss and those considerations. You've got medical management. You've got the DPC function. What are we doing for networks? All of those kinds of things. Very strategic. The problem that I see in my space, particularly among the larger brokerage and consulting firms out there, is they have a tendency, I'm not saying they're bad firms. There's lots of good firms out there. But generally, they have a tendency to take something like this and productize it. Make it a product. so then they can distribute it to their sales teams. Because think about it. If you're out selling widgets, it's look at this. Look at how cool it is. I want you to buy it. But if you try to implement DPC as a product, an off-the-shelf, polished solution, then it's going to get lost in translation because the incentives are misaligned. Salespeople sell to make money. What we're trying to do is position this as a solution to the healthcare dilemma. And we're not able to do that if we just sit there and talk about how great it is and that the fact that we want you to buy it, employer. What we're really doing is taking a step back and really looking at how we've been able to be successful in this space with integration is because we're promoting outwardly to the employer and the employees that we understand the dynamic that exists in healthcare, particularly the complex dynamic of delivering a health plan into a group of, or into a population. So that, I want to remind everybody, when you're looking to partner with somebody, really make sure, go to great lengths that they're not selling your message or telling your story as a product, because this is not a product. This is a number of different strategies that starts big picture and you get granular in terms of how you're plugging and playing different organizations, different strategies, different funding mechanisms, all of those things. So I wanted to be, and I'm glad Kat brought that up, because more and more and more brokers all across the country are starting to adopt this kind of process, this kind of story. And the reality is, then the salespeople go out and sell it. So if you go down that path with a partner and you see it starting to be sold as a product, step back and say, let's understand the dynamic here. Why are we doing this? Yes, we're doing this to deliver better, more quality care, but we're also doing this to save money, to spend our healthcare dollars wiser. And you can't do that as a product, because if it fails, then all you have is a product to blame. And that doesn't work well for anybody, okay? So time's almost up. If anybody'd like to have a conversation, Lisa and I'd be more than happy to sit and discuss this case study in terms of how we were able to project these results. But otherwise, I want to thank you for allowing me to be here, allowing all of us to be here. A lot of smart people in this room, and just please continue to keep up the momentum in this space, because I see big, big things in this space. Thank you very much.